Hello, everyone. My name is Rhonda Fisher. I am the clinical program lead for team training at the American Hospital Association. And it's my privilege to welcome you today to our August webinar on equity in healthcare, putting patients first. We're all very excited to have Dr. Beverley with us here today. But before I hand it off to her, I'm going to go over some rules of engagement and announcements. So you can access audio by listening in through your computer speakers or through your phone. If you're having issues, you should be able to access the toolbar at the bottom to switch to either phone audio or computer audio. Please do note that you are in a listen-only mode throughout the presentation today. I'm going to be moderating a Q&A session at the end with our speaker, however, so if you have a question, please do chat them in throughout the presentation. If it's technical or logistical in nature, we'll answer that in the moment, but if it's for our speaker, we'll save that for the question and answer time at the end. Please do note that this presentation is being recorded, and we'll notify all registrants when the recording is up on our website. Just to let you know, the chat won't follow through to the recording, however, so don't worry about that. Do make sure when you're chatting, it should look like the little picture there at the bottom of your screen where it says you're chatting to everyone. Just make sure that picture is present at the bottom, and that'll make sure it comes through to a place where everybody can see. All right, we are happy to offer free CEs for our webinars. In order to claim your CE credit, however, you do need to create a Duke OneLink account. This is a one-time only setup. My colleague Rachel has chatted in those instructions. You can also refer to the email that was sent to you this morning with the attachment. Following the webinar today, you're going to want to text that code you see up on the screen, RUMPUR, to the number you see on the screen. Don't worry if you miss it now, we'll share it again at the end. But that is the code you'll need to text in order to get your CE for today. I wanted to let you know of some upcoming events with AHA team training. First of all, we have a number of Team Steps Master Training courses coming up. The next one will be September 25th and 26th at Houston Methodist. If there's any OBGYNs on the call today, I want to let you know that that one also qualifies for your MOC Part 4 requirements, so that's an exciting development. We'll also have a course at Tulane in October, at Northwell towards the end of October, and then December 5th and 6th will be a course at UCLA in Los Angeles if you're needing a little summer sunshine. So those will be our in-person courses. In the meantime, we also have some wonderful webinars coming up for you. The critical role of nurse managers and nurse retention. Relias will be putting on that webinar. We know that that's a hot button topic right now. We'll also have a webinar on innovative care, the value of virtual nursing in a pediatric hospital, and then a clinical and culinary guide to healthy hospital food. That's going to be a fun one. So encourage you to attend as many of those webinars as you can. You can access more information on the slides. If you're looking for a more customized training solution, we offer on-site trainings where we come to your organization to deliver anything from a 2-day Team Steps Master Training course to a comprehensive training program that spans multiple on-site trainings and virtual coaching to truly support your implementation efforts and to help foster ownership and sustainability at your organization. We love these custom courses because it allows us to customize the content to your audience, to meet you, your hospital, your health system right where you're at. You can visit our website to learn more, complete a brief questionnaire, and one of our team members will follow up with you one-on-one so we can get started on a solution that's tailored to you and your organization. Okay, with that, I would like to introduce our presenter today, Dr. Mauvareen Beverley. She is the founder and president of Patient Engagement and Cultural Competence Specialist. That is who she is, what she does. She's also a best-selling author, and I will let her introduce herself further.
Thank you, Rhonda. Thank you for introduction. I just want to say good morning, good afternoon, good evening to everyone, depending on where you're located. And it's truly an honor to be selected to be a speaker at the American Hospital Association team training, Equity in Healthcare, Putting Patients First. Just a little bit about my background. I got my undergraduate degree from Boston University, and I attended University of Buffalo Jacobs School of Medicine and Medical School. And I did my internship and residency in internal medicine at Harlem Hospital, affiliate of Columbia Presbyterian in internal medicine. Currently, I am president and founder, as Rhonda explained, for Mauvareen Beverley, MD, PLLC, Patient Engagement and Cultural Competence Specialist. I'm also the author of my book. It's entitled 9 Simple Solutions to Achieve Health Equity, a guide for healthcare professionals and patients. It's a #1 bestseller in the new release category and also #4 in the health category. I have done training at various institutions, including Northwell, IHI, University of Buffalo General Hospital, Toro Medical College. And my presentation today is entitled Improving the Patient Engagement and Experience Roadmap. Thank you. So let's begin. So let's look at the background, purpose, and objective. So healthcare delivery systems are evolving with a focus on changing patient behavior in order to improve access, utilization, and health outcome. Less attention has been paid to the needed behavioral changes of healthcare professionals as our attitudes impact patient care. This program is comprehensive in its approach and is designed to improve patient care and experience in a culturally competent manner. In terms of purpose, we as healthcare professionals and executive leaders need to recognize that our beliefs and attitude, conscious and unconscious, can have a positive or negative impact on patient care, compliance, patient experience, the ability of patient to self-manage, and health outcomes. And the learning objective that I want to be a takeaway, we want to be able to increase empathy, respect and understand the individual's cultural beliefs regarding their health, prevent judgmental behavior directed at patients, prevent disparate care, maintain patient dignity, and improve health outcomes for diverse patient population. And with a focus I have on the elderly Black population who is not included in any of the conversations, particularly the cultural competence conversation. So let's look at self-evaluation. So what do we as healthcare administrators and professionals want to be? We want to be viewed as professional, knowledgeable, honest, caring, open-minded, non-judgmental, problem solver, and cultural competent. So what are our cultural beliefs and attitudes? What do we as individuals value? We value self, family, work, integrity, religious, culture, and ethnicity, finance, health, fun and recreation, privacy, dignity and respect, and choices. As you will know, choices is in red, and I will explain later as to why that's in red. So are patients really different than ourselves? I would assume that the patients also value the same things we do, as I mentioned before, and they also value choices as well. And let's look at our patients, the common thread. And I came to understanding patients after speaking to over 1,000 patients in 3 hospitals in New York City Health and Hospital. And what I recognize is that amid diversity, patients don't have a choice about their diseases. What do I say that? Once diagnosed accurately, it's non-negotiable. They can't give it back. In cases of chronic condition, the disease and its symptoms may remain with patients for life. Patients may be forced to change their lifestyle and/or job as a result of the disease, and there's temporary and permanent loss of control over one's life. And at any point in our life, we as health professionals may become patients as well. And when I say the common thread, it's the same across all health, all individuals, regardless of race, gender, ethnicity, socioeconomic status. The billionaire can't say, I'll give you $1 million to take the cancer back. Oh, that's not enough. I'll give you 5 million. And maybe if health system recognize the common thread, we could be more empathetic and less judgmental. And let's look at language of negativity in the medical records. Does it reflect high patient value? I'm sure everybody in the audience have heard the word or used the word non-compliant or non-adherent, but how many times have you seen the associated why question? Then there's the negative of the frequent flyer. It's almost that person is no longer human. High utilizer, gaming the system and deserving of punishment. Drug seekers, which is an unfair characteristic of patients with sickle cell disease. These negativity creates a culture of callous disregard and possibly contribute to poor health outcomes. So in terms of patients in our institution, what percent of patients in your hospital system get these negative labels? Is it 10%, 20%, 50%? Does negative label increase healthcare costs? Does the care given lack interest in the individual? Does it lack empathy, constructive dialogue, and information sharing? And is there a willingness to educate patients? So when I look at documentation in the medical records, documentation really, if ever, addresses the why, when non-compliant, and now there's a nicer word, non-adherent is used. Physicians and nurses are trained to ask why. Not asking why is counter to medical training and analytical thought process. So we'll see in the medical records, 37-year-old male, female, non-adherent with medication. The name of the medication may not be stated and the reason may not be given. And language of negativity. Does language of negativity cause potential adverse health outcomes, cause repetitive emergency department visits, cause increased readmission, and increased health burden for patients? Just a thought. So what we see now in the social history, is it comprehensive in describing the individual? Is the individual only being defined as non-drinker, non-smoker, or no toxic substance? The combination of non-compliant, non-adherent without asking why, coupled with no toxic substance, is now defining a human being. That individual is no longer valued. However, we are taught in medical school what should be included in social history. It's more comprehensive. If one's perception of the individual is the same as the reality, then there's an opportunity to make necessary changes. But if one's perception is different than the reality, we run the risk of increasing disparity in health outcomes. And I'll give you an example of this perception versus reality. So this is a true case. I was in charge of the congestive heart failure readmission prevention program at Kings County, and the patient was seen in the emergency room, and the information that was in the medical record said 60-year-old African-American male, recently diagnosed with congestive heart failure, returns 2 weeks later, heart failure decompensated due to non-compliance. When the patient goes up to the unit in any hospital, you think anybody is going to care for that patient? And so one of the nurses said, please, what do you want me to do? He doesn't follow directions. I got other things to do. And we asked, my team had to ask why. Why don't you take your medications? And he said, I can't take the water pill. Why can't you take the water pill? And I hope everybody's sitting down when you hear his answer. Because I drive the number 7 train. And so when is your shift? 11 p.m. to 11 a.m. What do you do when you get home? I do some chores. I make breakfast. I take some of my medication. But if I'm on my shift, I don't take the water pill. The same cardiologist who was ignoring him said, okay, take the water pill when you get home. Be aware that it may wake you up during the day, but by the time you get to your shift, you'll have less of a reason to urinate. But to the degree that you do, we're going to give you a cubicle so you could use in the private space when the train stops. You know, the patient said, if I knew I had to choose between peeing and breathing, I would have chosen breathing. And so let's expand the conversation. You know, without the why question, he would have been readmitted and multiple times, and now they may have even added a more negative word, frequent flyer. And if he were to pass that mortality, it would say died due to non-compliance. We were able to save this gentleman's life with a simple question, the why question. And so he didn't have to choose between his job and his health. So it's just the human experience. You know, the ultimate culture is the human experience. The non-negotiable disease, you can't give it back, and it may be present for life. And just when you look at individual value related to ethnicity, race, gender, socioeconomic status, education, and language. And then there's the cultural sensitivity belief system. English-speaking patients, non-English-speaking patients, and limited English-speaking patients. And if we all get an understanding, we can help to prevent increase in disparity, increase in mistrust, increase in non-adherence, decrease knowledge base, and decrease patient engagement. And so let's look at the concept of eradicating perception versus reality. So perception versus reality. So the COVID pandemic has shed bright light on the long-standing numerous health inequities experienced by Black Americans across the U.S. The Black population had the highest COVID death rate. The perception is that the prevailing thought is that it's a result of poverty, lack of access to care, social determinants of health, and comorbidities. The reality is, for example, Prince George County in Maryland, one of the wealthiest Black upper-class communities in the nation, has some of the highest COVID mortality. Brooklyn, New York, with a large Black population, has 13 hospitals, inclusive of 3 public, a state hospital, and extensive public transportation that runs throughout Black and white Brooklyn. But the Black population there had the highest COVID death rate. The public transportation employees who died were predominantly Black, who were union workers with an average salary of $50,000 with pensions and health coverage. And I think the reason why you saw a large Black population on the public transportation system is that they probably came in contact with about 1 million patients, before we learned and understood the ramifications of COVID. And so just a statement, we still see stark racial disparities even at high income levels, said Dr. Tanjala Purnell. She was Associate Director of Johns Hopkins Center of Health Equity. People say, oh, minorities are dying because they are poor. We know that's not the case. So the myth about sickle cell patients. Sickle cell patients have a higher degree of drug addiction than the general population. The fact is, opioid addiction for sickle cell patients range from 0.5 to 8% versus 3 to 16% in patients with other chronic pain syndrome. Behaviors often described as patients with sickle cell disease, such as requesting a specific dose of opioid or requesting that the opioid be administered intravenously, may be normative in patients who have experienced a history of undertreatment for pain, less indicative of abuse than behaviors such as illicit drug use or using opioids for symptoms other than pain. This is from an article that was published in JAMA. So the electronic health records, can negative information go viral? Is there a positive or negative association with the patient experience? Will EHR improve health outcomes when fed negative terminology in describing patients? Will the receiving MD, subspecialist, nurse, social worker, or receptionist want to engage patients that are described as frequent flyers, non-compliant, non-adherent, and drug seekers? So let's define cultural competency. Cultural competency is defined as an ability of providers and organizations to effectively deliver healthcare services that meet social, cultural, and linguistic needs of patients. A culturally competent healthcare system can help improve health outcome, quality of care, and contribute to the elimination of racial and ethnic disparities. So at Kings County Hospital, where I was in charge, as I said, congestive readmission prevention program. 93% of the population is of African ancestry. 50% of the patients are Caribbean, 39% African Americans, 4% Hispanic. The patients of non-white African ancestry were 3% white and 4% others. Approximately 80 to 90% of African American patients were from North or South Carolina. The Caribbean islands, the top four were Jamaica, Trinidad, Haiti, and Guyana. And three most common language was English, Haitian Creole, and Spanish. And the Spanish population was actually from Panama. And under colonial rule, the British sent the English-speaking population to Panama to do what? To build the canal. So phenotypically, they look black. Their language, first language is English, and they have English and Spanish names. Ronaldo, Austin, Antonio, Martin, as opposed to Jesus Rivera and other well-known Hispanic names. So the American migration history from North and South Carolina is very important to understand. By 1900, significant portions of African American population had begun migrating from North and South Carolina to New York to escape the atrocities of lynching, the Ku Klux Klan, and Jim Crow law. Just 35 years after the Emancipation Proclamation, African American communities had already begun to thrive. One community was the city of Wilmington, North Carolina. They built schools, they built churches, they built businesses. Over the course of time, nobody was picking the cotton from the plantation owners. And over the course of time, the Ku Klux Klan came in and burned the place down in terms of the massacre of 1898. And there's a documentary, the Wilmington Massacre, if anybody wants to look that up. So Kings County Congestive Heart Failure Readmission Prevention Task Force was 2011 to 2014. So my team had to ask the question and to find who is the individual, what are the fear factors. One of the things I realized that in healthcare, patient fears are not a part of the conversation. And you could see how a patient fear could lead to, quote, non-compliance. And what's important to the individual, we never ask. And where's the individual in the acceptance of the disease? Not what's important to the individual, we don't ask. We tend to say, tell the patient what we think should be important to them, but we never ask directly what's important to you, which my team had to do. And the team's philosophy, not to be judgmental, never use the word non-compliant without asking why, improve the patient engagement and cultural competence, identify African-American, Afro-Caribbean, recognize the heightened patient value. And when I say recognize the African-American, the Afro-Caribbean, is what I call the lookalike syndrome. We may all look alike and come from the same location and history, but what we want to know is understand the unique cultural differences between the population and what I refer to the lookalike syndrome. And that came from a group the group of us speaking to a patient, and he was Indian. And he said, where in India are you from? One of the nurses asked, and he said, I'm not from India, I'm Caribbean, I'm Guyanese, And so I say when I do presentation, go tell a British person they're Irish and see how far you get. Go tell a Chinese they're Japanese. Go tell an Indian they're Pakistani. Go tell a Nigerian they're Ghanaian. And go tell a Jamaican they're Trinidadian. And most important, go tell a New Yorker that they're from New Jersey and see how far you get. Okay. So the team had an interdisciplinary team was amazing. As you see on the slide, there were a lot of different departments involved. Hospitalist, social worker, dietitian, a pharmacist, home care agency, care case manager. We had a consultant, a cardiologist, nurses, and we had patients who were able to join the conversation and meet us at 9 o'clock in the morning if they were able to ambulate, and also the family could call in. And after we were able to decrease readmission for heart failure from 30% to 18.7 in a little less than 2 years. And the results from the 30% came from then the medical director, and the 18.7 came from the Department of Medical and Professional Affairs. So the patient voices, they are in our hospital beds and not in the history books, and here are their stories. So 83-year-old African-American female, originally from South Carolina, had 7 brothers, family were sharecroppers, and she stated, my family picked cotton on a plantation that was not ours. She also stated, I had to get up in the field by sunup. My family picked 400 to 500 pounds of cotton a day, and I had to walk 10 miles to a segregated school. And I'm saying, 10 miles? How do you walk 10 miles? We can't even go 5 blocks without calling an Uber, And I'll never forget her answer and the body language and her tone change. If you wanted an education, you had to walk. It was almost like, what part of this don't you get, stupid? You know? She completed her primary education in high school, attended Voorhees College, and this is almost 60 years later. It's a 2-year black college in South Carolina. And she was still upset with herself. I did not get into my second trial. She got married in 1948, had 2 children. Both her children graduated from college. One became an electrical engineer, and the other became a mechanical engineer. And if you're from New York, I'm sure you're familiar with Stuyvesant High School. Her 2 children were 2 of 5 black children to integrate Stuyvesant High School. You know, she continued her education, became a dietitian, later became a registered nutritionist, and retired in the 1980s. I said, salary retirement, $200 a week. And she said, others made more. Read between the lines. Religion Baptist. So an 80-year-old African-American female, initially from South Carolina, said, my parents were a step away from slavery and my grandparents were slaves. 82-year-old African-American, one day said, what I'm most concerned about is that I will not be able to go to church on Sunday. She was depressed. She was stop eating, stop participating in her care. And I said, everybody said, yeah, we need to call psych for a psych consult for depression screening. And I said, absolutely. But find out what church she goes. And let me speak to the minister. The minister came in and spoke to her and told her, even if you are not discharged on Sunday, I will come back and pray with you. The guilt-ridden individual was no longer feel guilty of not praising God. And the role of religion in this population is pivotal to their care. And, you know, what I see in hospital, when a Holocaust survivor comes in, we roll out the red carpet. The chief medical officer, the board of directors, the CEO, the rabbi will go and see that person. And so they should, because of the horrific circumstances that they endured. But when an elderly black person who fled the South because of Ku Klux Klan, lynching, and Jim Crow, how come we don't roll out the red carpet? And the atrocity happened here. And it's an opportunity to treat all atrocity survivors the same and to recognize that the role of religion in these 2 populations were pivotal to their survival. So 78-year-old African-American female, initially from South Carolina, was dissatisfied with her hospital experience, and she stated, I picked cotton in the South and I paid my dues. I don't deserve to be treated this way. How many of us in healthcare understands her point of reference? That's of a cultural origin. So let's look at new focus. So need for a new approach for communication with patient. We may want to ask ourselves the question and understand, what is the patient not saying that the healthcare providers are not hearing? I'm embarrassed to talk about my living arrangements. I may have not accepted the disease. I don't understand what you're saying. I can't afford the medication. I'm scared to death about my condition. I'm worried about the impact on my job and finance. I don't trust the medicines and I'm going to try home remedies. The other question is, what is the physician, nurse, and care manager not saying that the patient is hearing? I'm not smart enough to understand my disease. I am in low literacy group. Therefore, I have low intelligence capability. You don't think I'm going to follow your directions. You people don't usually follow direction. You don't see the need to value and understand my cultural beliefs. You don't see me as valuable as you. And the result is I may not receive the empathy, time, and resources to help me improve my health. And so a new focus, again, the question, what is the patient not saying that we are not hearing? And what are we not saying that the patient is hearing? You know, we want to maintain patient dignity while asking probing questions about medical history, personal habits, and behavior. And recognize that body language is a universal communication tool in a diverse patient population. I don't have to speak your language to recognize that someone may be angry, sad, or scared. And body language is 80% of communication. And so we want to improve and continuous improvement in cultural competence and be conscious about the time required for patients to come to terms and accept the disease. Because if I'm planning a vacation to go with my kids on a summer vacation and I took a mammogram and it's positive, I may not even know who I am at that time. And understand that patients have no choice but to accept their diagnosis, and they may need help coping with the disease and its impact on their life. and the lives of their loved ones. And the fear factor, the universal threat, I call it. Fear factor from patient, am I going to die? Will the treatment make me feel worse? Will I get better? Can I have a normal life? Is it my fault? Did God do this to me? Family fears, I don't have the resource to do this alone. I don't know if I can give the medication. What happens if I make a mistake? I can't live with myself if I made my family member worse. Can I afford not going back to work to care for a family member? What do I do if something goes wrong? Who can I call? And a lot of the patients said they don't know who to call because if something happens at home, who do they call? And it's something that we may want to look into. And the fear factor, patient comments on the fear factor. The medication side effects may elicit more fear and discomfort than the disease itself. You're on your own after leaving a doctor's office. If the information about the side effects of the medication was not clearly communicated during the doctor's visit, patients may not take their medication once the pharmacist explains the side effect. Patients may now be considered non-compliant, and patients may be perceived as not caring about their health. And can we value my culture if you don't value me as an individual? Low patient value can possibly turn competent professionals into incompetent professionals, create a culture of callous disregard, as I mentioned before, impact image of the institution, compromise patient safety, and cause preventable adverse events. If the patient is not valued, then I may be detached from the patient engagement process. I may not obtain the required consent. I may not be as effective in explaining medical issues and medication as well as I am capable of and should do. I may not engage the family. I may unintentionally influence other staff behavior, and I may unintentionally substitute do no harm for harm. Patient-centered care. Can we really call ourselves patient-centered medical home if we continue, and again, to use negative language, in obtaining their medical care? We don't apply the rules of cultural competence in delivering care to communities, to this community. Who are our patients? Not only they are English-speaking and American-born, but they are also from different countries, speak several languages, and may have different religious beliefs, have different expectations regarding their healthcare needs and the role of healthcare providers, may have different beliefs about the use of Western medicine versus herbal and/or home remedies. So the individual with a disease versus the disease label. So care management is about caring for individuals with one or more disease and as a result, improve the health of the population. Care management is not about broad brushing the disease to a group of individuals. For example, when one says diabetes, we also use the word diabetics. It may suggest that all diabetics are the same. The same disease is the same. The disease is the same, but the individuals with the disease are different. For example, there's a diabetic mom with 2 children. There's a diabetic father who works 12 hours, a diabetic grandmother who vehemently believes that she has to leave the disease in God's hands. And so what are some of the challenges? So not to have the patient choose between health and family, health and culture, health and religious beliefs, health and finance, and health and education. Challenge 2, to understand the human response and the time it may require for somebody to accept a new disease. We may need to engage the discussion about anger, denial, religious and cultural beliefs, and depression. Challenge 3, understanding the role of historical racism in inequities of healthcare system towards African American. Patient concerns, they are not telling me what's wrong. They don't treat me the same as Caucasian. I don't really believe what they say. Possible response, you may not believe it, but you need to listen to me for your own health. But the preferred response should be, would you like to tell me about your family's experience with the healthcare system? Based on what you have just told me, I can empathize and understand why you feel that way. Here is why this experience is different, and let me tell you why. The immigrant perspective, I should not question the doctor since he or she knows and understands health more than anyone. All immigrants are not undocumented or uninsured. Limited English proficiency and accents are not indicators of intelligence. Low English proficiency patient possibly respond, please repeat what I just said. Did you understand? Or what part of this didn't you understand? The preferred response, I would like you to tell me whether you understood my instructions, as I may not have explained it as clearly as I should. Giving me feedback would also help improve my communication with other patients. What most patients want is to be able to help other patients. Senior citizen, no longer valued, living on borrowed time, only limited communication is needed. Mental health, the patient is a substance abuser. He or she is at fault, therefore he or she is of questionable human value. They are frequent flyers, abusers, resources, falling on the floor and don't know how to behave like human beings. If they would only take their medications, they would not have the problem. They're seekers and abusers of certain prescription drugs. That's the feeling, the perception. So what are the staff challenges? What kind of patients do you have difficulty engaging in the care process? Is it a nonverbal or non-communicative patient? Is it the angry patient? Is it, and there's a blank, you could fill in for yourself what patient do you have difficulty with? What's your comfort level with patients who are African American / African descent, Hispanic, Asian, Caucasian, American Indian? And let's go to bidirectional cultural sensitivity. Cultural sensitivity, a bidirectional approach. Foreign medical clinical graduates to American-born patients, American clinicians to foreign-born patients, and American clinicians to American-born patients who are culturally different than themselves. The English-speaking population is currently left out of the cultural competence requirements and conversation, particularly African Americans, as I pointed out before. We need to understand the role of race, gender in the American culture and race and gender in foreign cultures. Cultural sensitivity towards foreign-born patients. American clinicians need to understand cultural norms that are different from American norms. They include the role of the caregiver. The caregiver may not be the decision maker in other cultures, the role of clinicians in other societies. Example, I say you do philosophy. And American and foreign-born clinicians can develop a shared understanding. Patients, irrespective of birth, language, religious belief, and appearance, voluntarily came to our institution. They may have received a diagnosis that they did not want, which is non-negotiable, and the possibility of the disease being a lifelong burden requires major lifestyle changes and appreciation that there may be a need to understand where the patient is in the acceptance of the disease. So patient-centered care starts with give the patient the benefit of the doubt, be non-judgmental, increase empathy, eliminate the negative labels I mentioned before, frequent flyer drug seekers, high utilizers, non-compliant without why. Recognize that the average healthcare professional is healthier than the patient's population, and most have never been hospitalized. And those that have been hospitalized were women delivering birth, and in some cases, patients are trying to prevent death. So the lessons learned. So behavioral changes starts with healthcare professionals and executives. Professionals and patients share the same human concerns and emotions. Illness trumps religion, ethnicity, race, gender, and culture. Historical trauma can influence patient behavior. Terms such as frequent flyer and the negative term used over time in healthcare settings towards patients can create a culture of callous disregard. A culture of callous disregard can negatively impact patient health, safety, and affect patient compliance. We can all be patients at any given point in time. So this is just an instruction from a patient. For me to change from the bush tea, you have to tell me the severity of why you want me to add 1 or 2 medications. If you want me to add 3 or 4 medications, you have to personalize it, man. Patient-centered care, who knew? And communication. During 2 weeks, this is just something I read. During a patient's 2-week follow-up appointment with the cardiologist, he informed me, his doctor, that he was having trouble with one of his medications. Which one, I asked? The patch. The nurse told me that to put on the new one every 6 hours, and now I'm running out of place to put it. I had him quickly undress and discover what I hoped I would not see. Yes, the man had over 50 patches on his body. Now the instructions include remove the old patch before applying the new one. And just some African American history, as we improve our communication with patients and each other, it may be helpful to know that Henry Sampson Jr. invented the gamma cell for mobile phones and wireless communication, the first African American PhD in nuclear engineering in the United States, and communication has power. And lastly, these memorable quotes that are embedded in my brain: difficult patients are not just born, they're in part created by this passage through the medical system. Not only has the system failed to cure, it may have done unpleasant things to make matters worse. And this is from Disorders of Hemoglobin, Steinberg. And Hippocrates is more important to know the person who has the disease than the disease who has the person. Hippocrates knew that thousands of years ago, and we are just learning that now. And so I just put on the slide information about my book, 9 Simple Solutions to Achieve Health Equity, a guide for healthcare professionals and patients. You could scan the QR code to order the book. It's on Amazon. If you want an ebook, the information is there, the paperback. And my website, drbeverley.com. And if you want to contact me, please email me at mbeverleymd@gmail.com. Thank you so much. Thank you.
Great. So thank you for that insightful presentation, Dr. Beverley. I want to encourage everyone to go ahead and put questions into the chat since we do have some time for that today. I want to read one comment that I saw flow into the chat from Myra. Thank you so much, Myra. She said, amazing. Thank you for your research and presentation. Culture, race, and ethnicity sensitivity is greatly needed to provide the best patient care. We need to hear and see more of this so that it can become normally implemented in visits to hospitals, government offices, courts, police departments, supermarkets, all of our community. This is total health care. So I thought that was a great summary, Myra, of the point we're trying to drive towards today for sure. And there was a question here, Dr. Beverley, given the complexity and fast pace of healthcare today, how do we as healthcare team members create that trust and space for psychological safety to ensure patients can bring up their concerns transparently in real time?
Yeah, I think it really comes down to increasing the human value and to recognize, looking from internal ourselves, what is the perception versus the reality of this person? Do I have the wrong perception, or what is the reality? Because that's where I think unbiased and biased attitude starts, and I think it just would be important. And to ask the question of the patient, could you tell me what's important to you? Not what I think should be important to you. And I found out when we asked what's important to you, we were able to get a lot of information and to recognize the fear factor came up in one of the discussions. So, and I said I do training, and I'd be happy to have any institution reach out to me about doing the training process on patient engagement and cultural competence training, because that was a really important question. Thank you.
Yes, I see another question in the chat. Do you think the implicit bias association test is of value for all healthcare professionals?
I think yes. Yes, I do. Because it's something that each individual may not have implicit bias, but from my perspective, let's take a medical student. When a medical school student graduates and is now going into an institution, if that institution is toxic towards, let's say, African-American patients, 6 months later, that person is going to be toxic as well. Was that person initially have implicit bias? No. But when they go to the system, what is the system responsibility to be able to continue who that individual was? in the setting. And I think that's where I see changes can occur.
Matt, another question in the chat here. How can we build cultural competency of medical staff tailored to our local population and history?
I'm sorry, Rhonda, could you repeat that?
Yeah, sure. How can we build cultural competency of medical staff tailored to our local population and history? Any suggestions there?
Yes, I think you would have to understand who is your population. Who is the population that you're serving? And then reach out to the community or patients who are in the hospital beds and ask, what is it that you would want me to understand about your culture? And in my book, what I refer to as stop in my tracks moments that resulted in boots on the ground, simple solution came from the actual patients in the bed. And it addresses the perception reality. So I'll give you a quick example. I asked doctors, heart failure patients taking what, 5 or 6 medication 3 times a day? Why don't patients take their medication? And everybody in the ED and the inpatient said cost. This is in Brooklyn, New York. So it sounds like it makes sense, right? What if I told you when I asked the patients in the bed, why don't you take your medication? Not one person mentioned cost. Guess what the only answer was? We don't take our medication because we think we're taking too many medications. So if you design a system based on the perception of cost, then it's going to fail. But if you don't recognize what's important and what the actual patients in our bed are saying. So what did we do? We brought in a pharmacist to collaborate with the clinical team. Could we cut down some of the medication? Could we combine the antihypertensive and the diuretics? Does the 82-year-old still need to be on a statin? All the anti-inflammatory medication that patients are on. And we were able to cut that down because we listened to who is in the bed. So I think it applies to culture as well. And we were able to do a presentation at the Patient Safety Council when we presented what we found in terms of what's important to the patient in terms of the medication, decrease in the amount of medication. So you see how that could actually improve readmissions if we understood that. Yeah.
Here's a question. What are the challenges to integrate culturally safe care and trauma-informed care and overall healthcare system and patient-centered care? So I'll repeat that. What are the challenges to integrate culturally safe care and trauma-informed care in the overall healthcare system and in patient-centered care?
That's a good question. Very complicated question. I think first it would be to assess what is the culture within that system first and foremost. What is the culture? Is it a positive culture towards patients? Is it a negative culture towards patients? And that has to come from the chief medical officer, the board of directors, the CEO of the hospital, ambulatory care, get together and define how do we see our system in a positive or a negative. And one of the things that I recommend is that, you have the HCAP scores when everything comes out, what does patient think about the care they receive? Would they recommend the hospital? But you never hear, what does the staff think about the population they serve? So I would start with surveys about what does the staff think about the population they serve, because you could see how it could have a positive or negative impact on healthcare, and the HCAP scores. If we knew, but I've never seen, and I researched, I've never seen any survey, and that's what I created and recommended in my book. Do a survey from your staff, from all levels, and to see what is the perception, or what is the perception of the population they serve.
Okay. There are lots of questions flowing into the chat, so my apologies if I accidentally skip over anyone here. But there was a question, can Dr. Beverley elaborate about data collection and analyzation and how it will support our journey towards health equity?
For data collection?
Yes, data. How can you elaborate about data collection and analyzation of data and how that would support our journey towards health equity?
Well, I would need to understand what data collection are they the person is referring to. What is the data that you're referring to? And to see whether it's already accessible within your system. So I would need to, and maybe that person could reach out to me and email me, and we could have a conversation about that topic. Because I need to know what data, you know.
Great. And you'll notice that Dr. Beverley was generous enough to put her email at the bottom of the screen here. So those of you who didn't get your questions asked or answered, be sure and reach out to Dr. Beverley. I'm sure that she would welcome that.
Yeah. And, you know, and any institution that's willing to do a collaboration on achieving health equity through the 9 simple solutions in the book, once they read the book or purchase the book, I would be honored to have a conversation as well. Because I think it's really a game changer. And the reason I'm looking for it's a game changer because it's sustainable. So some of the systems that I put in place are still operational till today. One is the sickle cell support group in Queens and the concept of the bridge team in Elmhurst. Bridge the gap. I don't care what the gap is. And the bridge team is still operational and it's showing results.
Right, let's just do one more question here. There were a couple of questions that I noted in the chat on the topic of, is cultural competence training or education included in medical school curricula? Yes or no? And if not, how can we potentially make sure that moving into the future that this type of information is certainly presented in our medical school and nursing school training for that matter?
Yeah. Good question. And one of the things I'm looking at actually is to collaborate with medical schools to see what is in their training program related to health disparity towards health equity. And, you know, I've reached out to a couple of medical schools, schools, and I've gotten a response from one that we're going to schedule a call and to discuss. Because the person read, you know, the person that the chief medical officer there read the book and wanted to collaborate, because I think it would be good to just have the conversation, and it has to come from internal individuals who have the power to change the system. So I'd be happy to have that conversation as well for medical school. As I said, if you graduate from medical school and you come into a system that's toxic towards a particular population, 6 months later, that individual is going to be toxic as well.
Yes. All right. Well, we're closing in on our last few minutes together. So again, want to encourage you, go ahead and reach out to Dr. Beverley personally. If you have more questions for her, she'd be more than happy to talk to you. Just a couple of final reminders. After the presentation closes today, an evaluation will pop up on your screen. So please do take the time to fill out that evaluation, because that will give invaluable information to Dr. Beverley and to us here at AHA Team Training on how we can improve things, or else reinforce what you liked to see today, would like to see more of. So please do fill out that evaluation. Also, a reminder that you will need to create a Duke OneLink account if you have not done so previously. The instructions can be downloaded from the files pod or your registration confirmation. And once you've created that Duke OneLink account, you'll want to text that code RUMPUR to the number that you see up on the screen. So take out your camera, take a picture, jot it down on a piece of paper, because you've got 24 hours to text that code to that number on the screen in order to get your CE credit for today. So thank you very much for joining us today. We appreciate that you took time out of your busy schedules to join us. We hope you'll join us next month for the AHA Team Training webinar, and have a great rest of the week. Go forward and be culturally competent.
Thank you to everyone for joining. I really appreciate the questions, and it definitely says that we're collaborating on the same topic and we want to see change. So thank you again, American Hospital Association, for inviting me. Much appreciated.